We're going to start out with vascular, and we're going to tick through the sections a little faster today. And then this afternoon is going to be really critical. I'm going to be giving you case after case after case after case of unknown, and then discussing them. And they will concentrate on about 7 or 8 sections. So first I want to focus on vascular. And so I'm going to show you a few vascular cases, and then the vascular cases will come fast and furious in the afternoon. When you're looking at a vascular case, and you might say, well, how do I know it's a vascular case? Patient comes in with acute neurologic deficit. It's a vascular case. Patient has sickle cell disease, and they have weakness of the right hand. It's a vascular case. Use your medical skills to apply to radiology. So you're going to look at every flow void quickly. The major ones, carotids and vertebrobasilar, and some of the major branches. You'll look at every single relevant dural venous sinuses, vein of Trillard, vein of Lebet, superior sagittal sinus, transverse sinuses, sigmoid sinus, jugular vein. You're going to look at the CT, you're going to window it tightly to see if there's a stroke, and then you're going to look for petechial hemorrhage. If it's on MR, you're going to look for, again, a stroke. You'll use diffusion imaging, you'll use your FLAIR. You'll also want to know how big the stroke is. Strokes that are greater than 1/3 the volume of the hemisphere, especially in the MCA distribution, have a bad prognosis. You're going to look for macrohemorrhage. You will take note of petechial hemorrhage, which is not a contraindication for anticoagulation. You are going to look at, on diffusion imaging, restriction. And you're going to look for a volume of restriction. Usually 70 is about the cutoff. So 70 is about the cutoff for when things really start to go awry, and also when you are strongly considering reversing a core of infarction. Later on this afternoon, we're going to focus on things like core and penumbra and perfusion and mean transit time, cerebral blood flow, cerebral blood volume, and what they mean. You're going to try and date the stroke. You're not going to treat a stroke that's 6 weeks old or 9 weeks old. You want to get in there at somewhere between a few minutes and 1 to 2 hours. That's ideal. 3 hours, okay. 4 hours, pushing it. 5 hours, maybe in the posterior fossa. 6 hours, probably the absolute cutoff that any major institution will agree to anticoagulate. You can anticoagulate peripherally. You can go in and extract clots, and you can go in and focally infuse thrombolytic agents. The decision as to which you choose is going to depend heavily on the clinical and where the infarctions are. Are they proximal? Did they occur in the carotid where you could do an extraction? Or did they occur in the MCA, M1 or M2 segment? Or did they occur in the M3 or M4 segments, the opercular or the insular segments? Those patients are not candidates usually for anticoagulations because their strokes are not severe enough. They do better without anticoagulation. You'll use your CT skills. You'll look for things like the hyperdense middle cerebral sign, which I'll show you a little bit later. You will look at collaterals, which are probably the major determinant of how a patient does. You'll look to see the geography of the stroke. Is the stroke a PCA stroke, an MCA stroke, or is it none of the above? Is it from a global anoxic event? Is it watershed? Or, most importantly, is it a venous infarction with a geographic edge, with some blood in it, not corresponding to a vascular territory? You're going to look to see if there is mass effect and midline shift, a very ominous prognostic sign. Is the stroke multifocal? Is it round? Is it subcortical? If it's multifocal, maybe it suggests multi-infarct dementia or some systemic underlying metabolic or vascular condition, including vasculitis. If the strokes are multifocal and round and somewhat peripheral, you might consider thromboembolic strokes, especially if they are hemorrhagic, and check the patient for endocarditis. Is the patient cognitively intact? For multiple strokes can produce, along with small internal deep strokes, as in Binswanger's disease, dementia. And there are different types of vascular-related dementia, from hypertension, from MID, multi-infarct dementia, or from deep small vessel disease, so-called subcortical arteriosclerotic encephalopathy, or Binswanger's syndrome. What is the size of the stroke, as alluded to earlier? And you saw a case of both asymmetric and symmetric stroke in the same patient in an individual with Melas syndrome, a mitochondrial cytopathy. And finally, if the patient has a vascular injury, is it reversible? In other words, is the diffusion image negative, yet you see a stroke-like abnormality elsewhere, which may happen, not always, but it happens in PRESS, posterior reversible encephalopathy syndrome. Now, some patients with PRESS will have foci of true infarction with diffusion restriction, so that is not a hard and fast criteria. But as a general rule of thumb, PRESS, reversible encephalopathy syndrome, will have a relative paucity of diffusion abnormalities. So that is my somewhat long-winded, but I think important introduction to vascular disease. Now let's get started. Okay, the history is, thank you, neck pain, edema, soft tissues in the neck for 1 week, and the patient is 8 weeks pregnant. How many of you have daughters? Less than half. Wow. Something must be wrong here in Australia with the water. This is an important case for your daughters. And that includes everyone, including our videographers and our sound people. Because everybody has daughters at some point or another, or a mother, or a sister. Now, you can watch me, but that would be cheating. But I would call it soft cheating, because how could you not look? I'm giving you a little extra time. Now, one thing you will recall from my prior discussion is, in a vessel, you have blood and clot. Clot behaves similarly in a vessel as it does in the brain. Not identical, but similar. The differences are that the speed with which the signals change are a little different in a vessel. You get recanalization in the center of the vessel, so sometimes the clot will persist on the outside, but not so much on the inside, and obviously the shapes are different. We made a very important point, that gray signal on T1 and gray signal on T2 are contentious signals in any vessel. If you couple this with vessel expansion, or what I call holovascular signal replacement, that's probably good enough to make the diagnosis of a thrombosis. Even better and highly consistent is swelling and edema due to increased vascular pressure and extravasation of fluid and inflammation around that vessel. So now, with that information, what do we think is going on? Let's start out with something easy that we're all comfortable with, the axial. On the right-hand side, we have a carotid artery and a subclavian vein. On the left-hand side, we have a carotid artery and a globular, gray, smooth, homogeneous, almost solid-looking replacement of the left jugular vein. I say we go south, we go inferior, caudad, and we see the subclavian vein. We go back up to the jugular vein, subclavian vein. So we've got a patient with subclavian vein thrombosis. The arm is swollen. We can see that directly on the T1 MR. We can see it directly on the sagittal MR, swelling in the supraclavicular region. That swelling persisted towards the midline and peripherally into the axillary space. Let's try and sort out some of the key anatomic structures in the sagittal projection. First of all, why did this happen? Most likely in a pregnant woman, it happened because she has an underlying metabolic syndrome. Second most likely, a morphologic abnormality. What would be the most likely metabolic syndrome? For everyone out there that has a loved one who is a woman, factor V Leiden has to be evaluated in any woman that has ever had any kind of clot in their life, or they're on birth control pills and they get a headache. They're either homozygous or heterozygous for this gene. And if they have it, they can never be on birth control pills. And if they get pregnant, then they have to be consulted by a hematologist, an oncologist, to see if there is minor anticoagulation needed for the pregnancy if they're homozygous. This is not a rare entity. You're saying, well, why don't I know about it? It's new. How new? 5 to 7 years old. But it was described and discussed by a great and famous, now retired hematologist, oncologist from the Midwest. So it's real. We go to the jugular foramen. Things are getting more ominous. It's big, it's fat, it's gray, it's smooth. It's not good. Let's keep going to the lateral sinus. Slow flow, in-plane slice entry phenomenon, white on T1, but not gray on T1, not smooth and gray, not almost solid looking. The lateral sinus is thrombosed. The sigmoid sinus was thrombosed. The transverse sinus is thrombosed. This is a life-threatening abnormality. Aggressive anticoagulation is necessary to save this pregnant woman's life. So we said metabolic syndromes, and I'm not going to try and impress you with the whole list of metabolic syndromes. You can get on the internet, but I've given you one of the most important ones. There are some other very obvious ones that are usually preemptively diagnosed during screening. But factor V Leiden is not a typical screen. And I've listed them for you before, things like antithrombin 3 and the classic ones. Hypertriglyceridemia would be another one. And then there are some really unusual but important ones like cryoglobulinemia, and perhaps we'll discuss those a little bit later. I'll have the entire list for you in MRI Online of every single hypercoagulable state that you can ever imagine, including paroxysmal nocturnal hemoglobinuria, which is another one. And we said subset, first subset, metabolic. Next subset, anatomic. So let's talk about anatomic, and let's talk about the anatomy of this area. We're going a little longer on this case because it's so important and so complex. So right here is your clavicle. What's underneath the clavicle? The subclavius muscle. One of the uncommon causes of thoracic outlet syndrome is subclavius muscle hypertrophy. Unfortunately, she has it. I'll blow it up a little bit. She was checked for factor V Leiden. She is heterozygous, so she's got 2 risk factors for thrombosis. Now, unfortunately, the anatomy is rather distorted, and you're going to see the occluded subclavian vein. Here's your subclavian artery. And then another area that is at high risk that is completely obliterated by swelling edema is this triangle, which consists of the not very well seen edematous middle and posterior scalene, in which the brachial plexus, I'll blow it up for you, the brachial plexus sits right here. These two little dots are part of the brachial plexus. And at this level, the brachial plexus is divided into an anterior, middle or medial, and posterior cord. Paul Bohart, who is a fantastic medical illustrator, helped me write a beautiful book on entrapment neuropathies. And in that book, we describe early on the 3 zones of entrapment neuropathy, and they occur from the cervical spine and superior border of the mediastinum to the lateral border of the mediastinum, and then to the lateral border of the pec minor. And these 3 zones, most medially, and most importantly, are the scalene triangle, which is right here. There's your scalene triangle. Again, unfortunately, this is edema, that's edema, and swelling, etc. But there's the middle scalene, there's the posterior scalene. You've also got the issue of the first rib, which sits inferiorly. Let's see if we can, well, I'm not going to try and spot the first rib right here. Let me switch back to show you the anatomy. So subclavian vein, subclavian artery, scalene triangle. This would be middle scalene. This would be posterior scalene. The anterior scalene, mostly a throwaway. So then just inside this triangle, you'll see some grayish-looking structures. They'll be seen in a pristine, non-edematous scalene triangle, but here they are. Here are at least 2 bundles of the brachial plexus. And then here is, again, your subclavius muscle. So let's see if we can spot the first rib. We can. Let's get the highest rib right there. And so again, 3 zones from the cervical spine and superior border of the mediastinum. Sorry, the scalene triangle is the most medial. Intermediate is called the costoclavicular space. It is bordered by the subclavius anteriorly, which you saw, the clavicle superiorly, and the first rib and anterior scalene muscle inferiorly and posteriorly. So in zone number 2, the anterior scalene comes into place. This contains the neurovascular bundle. The most lateral compartment lies outside the inferior aspect of the clavicle and is known as the subcoracoid pectoralis minor space. The neurovascular bundle courses between the pec minor anteriorly and the ribs and intercostal muscles posteriorly. The most common type of thoracic outlet syndrome is neurogenic, usually associated with a hyperextension neck injury or whiplash. Sometimes you'll get it repetitive motion with an outstretched hand, and this can happen in javelin throwers and American and Australian baseball players. Baseball is becoming more popular now in Australia. Unfortunately, the venous type of thoracic outlet syndrome is more common in baseball players and javelin throwers and is more contentious and life-threatening, like this case. Hypertrophy of the scalene, bone abnormalities, fibrous bands are all components and causes of TOS1. They have the typical syndromes of paresthesias and neurotype syndromes. However, they do get rainouts. And the reason they get rainouts is the sympathetic system becomes overactive. And frequently they'll complain of tingling in the fingers. They might have a little tenderness in the supraclavicular area, the pec minor, and the scalene. The end stage of this syndrome is called the Gilead-Sumner hand. It consists of atrophy, hyperesthesia, and the ulnar and medial anti-brachial cutaneous distribution of the median nerve. The second most important type, or common type, of thoracic outlet is this one, venous. It's the most life-threatening. We see it more commonly in athletes, young athletes. It has resulted in the death of several American baseball pitcher athletes due to stroke and other embolic phenomenon. It is not to be trifled with. The compression is at the subclavian, where there is then propagation in both directions. What we have here, propagation up and propagation out. There is venous compression at the costoclavicular space, zone number 2, usually between the first rib and the already shown subclavius muscle and clavicle. Most patients present with subclavian thrombosis first, and this is known as effort thrombosis. Another name for it is, for you syndrome lovers, Paget-Schroeder syndrome, although some present with intermittent venous compression without thrombosis. So they clot, they lyse, they clot, they lyse, and so on. The mechanism is extreme abduction. Patients are very muscular, but bone abnormalities are rare, except maybe subtle occult irregularity of the medial first rib, which is now just being recognized and described by Sheng in the Journal of Vascular Surgery. These abnormalities are of rapid onset, as you might expect, with acute clots, and most of these patients participate in vigorous sport. The third type of thoracic outlet syndrome clinically, we've got 3 zones and 3 clinical presentations. 3 clinical presentations: neurogenic, venous, arterial. Arterial is by far the rarest, 3%. It's usually due to damage to the subclavian vein or emboli. It's almost always associated with bone anomalies, cervical rib, anomalous first rib, or clavicle fracture. Just a couple of other comments regarding the anomalies that you might see. Another potential anomaly is broad hypertrophy of the T7 transverse process. Another anomaly would be a ligamentous attachment between C1 and C2 ribs that compresses the neurovascular bundle. In the venous form of thoracic outlet syndrome, there are both bone and soft tissue abnormalities, not infrequently. Collaterals are common, and this patient has so many collaterals, it's hard to articulate where they're coming from. Look at all of these flow voids here. I don't know what to name them, but they are flow voids. There's also eventually narrowing of the venous complex. So if this goes on for a while, the veins will collapse, they'll scar, and then you're in real trouble and you have to go to some type of venous grafting. In arterial outlet obstruction, there are bone and soft tissue anatomic abnormalities. The patients develop aneurysms, pseudoaneurysms. So if you see a pseudoaneurysm in a 30-year-old man or woman and you have no other explanation and there's no vasculitis, you think thoracic outlet syndrome. As stated, emboli, oodles of collaterals, and they too, after a while, develop collapse of the artery with stenosis and may require grafting. In the neurogenic form, patients often have edema either in the plexus or around the plexus. The edema is diffuse, it's ill-defined, the vessels are swollen, and this is not usually a presentation for a woman with breast cancer that has neurogenic brachial plexus syndrome. They have a mass. You are hunting for a mass. And the best way to do that is with 3D isotropic coronal imaging, T1, spur, T2, and then start to twirl it and move it around along the axis of the brachial plexus. Here's my summary for you, all on MRI Online, of the potential bony contributions to thoracic outlet syndrome. Cervical ribs. These occur in 6% of all TOS patients. They can be complete or incomplete. Complete accounts for about 30% of all the cervical ribs. They attach to the first rib by either fusion or a joint. The incomplete type is more common. It varies in length, and sometimes that attachment is ligamentous to a rib. They lie in the plane of the middle scalene. elongated C7 transverse process. It's defined as longer than the process of T1. There's no articulation, but it may have a ligamentous band. Anomalous first rib we described, anomalous first rib connected to the clavicle. TOS surgery is major league. The complications are serious. Hemothorax, pneumothorax, chylothorax. Some lesser complications that are more chronic include dehiscence of the lung up. So it produces an apical herniation of lung, so-called apical pleural hernia, phrenic nerve dysfunction, and a remnant of bone or muscle that regrows and exacerbates the disease. I'm going to stop right here on the imaging bone anomalies, which you will find in MRI online, but the take-home message is if you have a patient having an operation for thoracic outlet surgery, you vet that surgeon hard. We want somebody that's done 50, 70, 100, because this is not a simple procedure, and the complication rate is significant. This one's more simple. I would suggest you go to the fourth set of images, the MRA, and scroll. Now, there's a method to my madness here. I don't think the MRA MIPT information is all that informative. Let's go to the last MRA and scroll, rotate in an AP orientation. And now let's go to series number 3, or the third block set of images. And we start with an MRA and proceed to raw data. I'll give you about 15, 20 seconds to assimilate and digest. Okay. You've had an opportunity to come up with your own diagnosis. There are a REIT, a network of small vessels that are surrounding the left lateral sinus, depicted here. They extend for a variable distance. They start to fade away as we reach the sigmoid sinus, although the amount of contrast enhancement in the left as opposed to the right sinus is greater. As stated previously, it is not uncommon for the right jugular vein and its foramen to be 2. I've even seen it as much as 4 centimeters larger than the left, and that, as long as it's smooth, with a normal jugular tympanic spine on CT, does not bother me. So our diagnosis is a vascular abnormality, this one in its most characteristic location along with the carotid cavernous area, and this is known as a dural AV F, a dural AV fistula, which some might consider a subset of of an arterial venous malformation. But it is not parenchymal, and it is related to the dural venous sinuses. So let's talk about these a little bit, because they're often missed, and they are often missed in the spine, where you're going to see some in the spine section. The misses are catastrophic in the spine. 80% of all radiologists that I've ever encountered, no offense intended, have missed a dural AVF on more than one occasion. Typically, I am seeing the 6th MRI of a man who has paresis that is ascending with a sensory level. And the diagnosis is made at that point, and it's too late. We're in the brain right now, and unless you have the raw data of an MRA from a tip-off, either diagnostically or from a prior conventional MRI, you're going to miss it. This is where the diagnosis is made. So here are some features I would like you to focus on. First of all, where is the fistula? So they're usually right here along the lateral sinus. Second most common location is going to be up near the cavernous sinus. And those can be acquired or they can be congenital. So they can be acquired from trauma. Next, is there cortical venous drainage? Next, what's the direction of flow? Is the fistula moving in or is the fistula moving out? And finally, is there venous ectasia? And the answer in this particular case is yes, there is some, although the patient does have relatively large dural venous sinuses. Let's talk about the Cognard classification of dural AVFs. They're confined to the sinus, and they have antegrade flow, with flow along the direction of the sinus, but no cortical venous drainage or reflux. This patient does have cortical venous drainage and reflux. Type 2. 2A, confined to the sinus, retrograde sinus reflux, no cortical venous drainage. In other words, they are draining retrograde in the sinus, but they are not extending outward. 2B, they drain into the sinus with reflux into the cortical veins, and they have antegrade flow. And then there are combinations thereof. Type 3, they drain directly into cortical veins, but they don't drain into the sinus itself. 40% of these will bleed. And I'm going to switch over in a moment and show you the direction in which these dural AVFs will travel by button. And type 4, they drain into the cortical vein, not just the sinus, with venous ectasia. 65% of these will bleed. Let's scroll this one. I have it up. And I think there is venous ectasia in this case when you compare side to side. There is some cortical venous drainage. The direction of flow in earnest is hard to ascertain unless you have a more dynamic assessment of this patient. However, there are inordinate veins draining this way, retrograde, and there are inordinate veins compared to the other side draining antegrade. So in my personal opinion, there's antegrade flow, there's retrograde flow, it's a mixture, there's some cortical reflux, the vein is distended, and this is a patient with a high risk for a bleed, probably 50% or greater. And then finally, in the spine, there's spinal medullary venous drainage with progressive myelopathy, and we'll talk about how we apply the Cognard classification or other classification systems in the spine where it's even more critical to make the diagnosis. All right, this is a dural AVF. I've given you a basic classification system that is commonly used amongst neurosurgeons, and I'd like to move on to the next case unless there are any questions. Drooping of the left side of the face. It sounds like Bell's palsy to me. Now, if you want to change the orientation of your image, you can hit the greater than button at the bottom. And just keep hitting it until it goes into the right orientation. Either one will work. So the greater than button would look something like this, for those of you that forgot math. Or the less than button. Let's do a little scrolling. Got the left PCA, the right PCA, the SCAs, the basilar. What's this one? Maybe kind of a low ICA. Keep looking at it. Either a low ICA or a high pica. Okay. Let's go to the raw data. I'm going to put them two up. I'm going to put up both this reference image here on the right, and then I'm going to put up the original raw data images on the left. So here's our basilar artery. And if you're wondering, that could have been an anomalous pica, worry no more. It's not going down towards the tonsillar loop, so it must be a slightly low positioned ICA. In fact, it is. So let's follow our ICA on the left. And one of you was asking about this earlier, and our vessel is sitting right on top of the base of the 7th and 8th nerve complex. And the history was drooping of the left side of the face and facial spasms. So the patient has hemifacial spasm. And the typical cause of hemifacial spasm is vascular effacement by either a high-riding pica or, more commonly, an invaginating ICA. You'll see loops extending into the 7th and 8th nerve complexes all the time. But unless you have a clinical correlate, an absolute trusted clinical correlate, then you should not suggest the diagnosis unless the two go hand in hand. And we've given you some examples of that before. Those of you that are staying for the orthopedic course and are learning about orthopedic MRI, the Warwick criteria, recently developed for femoral acetabular impingement, mandatory that you have specific symptoms of FAI in conjunction with the morphologic findings. That is also true here. So this will happen all the time. Don't be an overdiagnoser. Don't miss, but it's much worse to overcall than undercall. This is a patient with hemifacial spasm clinically with an MR correlate that is an ICA invagination. So let me talk a little bit about vascular entrapment syndromes. And what happens is it's not truly an entrapment, it's a pulsation that irritates the superficial and myelin surface of a nerve and produces gradual attritional erosive change. So let's take a look. The most common and the most familiar to you is trigeminal neuralgia. It's a compression syndrome classically related to a tortuous, drooping, superior cerebellar artery. We already identified the superior cerebellar artery. Its course was normal. The mechanism, as stated, a zone of demyelination due to constant pulsation and irritation producing a lancinating pain in the distribution of the trigeminal nerve, often involving the second division, and the third division is the most uncommon. Trigeminal neuralgia is also called tic douloureux. In its most classic form, it causes extreme, sporadic, and sudden burning or shock-like pain that lasts from seconds to minutes per episode. The attacks last in succession in volleys as long as 2 hours. You're going to see some later, so I want to prepare you for it. And this is known as type 1 TN1, trigeminal neuralgia 1. In the atypical form, type 2, also known as TN2, the pain is constant, aching, burning, stabbing. It is, unfortunately, a cause for suicide in some individuals. Trigeminal neuralgia most often occurs in adults. So if you have a child with a trigeminal neuralgia syndrome, it is probably NF1 with a trigeminal schwannoma or neuroma, depending upon whether it's NF2 or 1. The symptoms may also be seen due to destruction of the myelin coat around the fifth nerve in multiple sclerosis. So MS patients also get a syndrome like tic-Dilleroux. So if you have an MS syndrome, it's usually a 30-year-old. If you have a TS syndrome or trigeminal neuralgia syndrome in a 30-year-old, it's probably MS. If it's in a 10-year-old, it's probably NF1 or 2. If it's in a 50-year-old, it is probably due to a vascular compression. More common in women than men, 12 per 100,000. The differential diagnosis also includes some other unusual disorders. Postherpetic neuralgia, cluster headaches, and TMJ disorder can mimic. There are numerous treatments. You can bathe the nerve, you can squeeze the nerve, you can burn the nerve with a gamma knife, you can do microvascular decompression. This takes a lot of skill. Find a good surgeon. It is the treatment of choice. I think I'm going to stop right there with my discussion on trigeminal neuralgia. And as you can see, the most common distribution is V2, 35%. V3 by itself is less common, but combined, there is some degree of commonality, about 20%. And just to clarify my earlier statement, V1 is absolutely the most uncommon isolated distribution for trigeminal neuralgia, but V1 and V2 can exist together. So previously that was a typo. V3 is affected about 30% of the time, but V2 is the classic. We've already talked about MS, but for some of these other conditions, there are other treatments like postherpetic neuralgia. You've got Lyrica, you've got gabapentin, you've got tricyclics. Glossopharyngeal neuralgia, lancinating pain in the back of the throat, often related to pica or vertebral compression. Atypical facial pain. This term is limited to patients reporting facial pain in the context of somatoform pain disorder. These patients usually experience pain that extends outside of a trigeminal distribution. Their pain complaints also involve other body regions, so you have to view these patients very carefully and with a lot of scrutiny. There's a high association with atypical pain syndrome and chronic fatigue syndrome or fibromyalgia. There are different drugs that are used to treat some of these syndromes. I reviewed them previously, a little bit beyond the scope of this particular discussion, and I'd like to go to hemifacial spasm. Who gets hemifacial spasm? 40 to 50-year-olds. What side? As in our example, the left side. It is the second most common cause of entrapment cranial nerve neuropathy. It's often related to ICA, sometimes ectatic basilar, occasionally a weird ascending pica. There is no real oral treatment. It is actually sometimes treated with botulinum toxin. And this is a very annoying syndrome that is chronic. The nerve is usually compressed along its parenchymal portion, and usually the vessel invaginates between the 7th and 8th nerve complex. Probably one of the classic articles written about this is by Tash in the American Journal of Neuroradiology in 1991, and you can read about it at your leisure. The history is occipital neuralgia, pain in the right anterior face for 6 months, retroorbital pain, ear pain. So multiple territories. As stated, the raw data of the MRA, not the MIPT MRA, is the most valuable contribution to the diagnosis of a vascular compressive loop syndrome. So let's have a look. I'd urge you to scroll the raw data. Unfortunately, there's a little bit of movement. Pain is on the right. It'd be lovely to find the fifth nerve. There are the fifth nerves. So far, I am not overly impressed with the fifth nerve. Quick look at our MIPT images. So in this case, let's turn our attention to the axial high-resolution 1.5 millimeter cisternogram. And we now beautifully see our fifth nerves. We see our sixth nerve headed right towards Dorello's Canal. There's Meckel's Cave. Our right sixth nerve is probably right here at the apparent exit. The real origin of the sixth nerve is over here. The real origin of the facial colliculus, bump, and facial nucleus is here. Brachium conjunctivum, middle cerebellar peduncle, just to occupy you while you're looking. Now, this is the second most valuable tool for entrapment neuropathy of a cranial nerve, and that is uber high resolution, heavily water weighted. Remember, there are 3 major heavily water weighted sequences at your disposal. Very T2 weighted, TR 6, 8, 10,000, long TE, isotropic fast spin echo. Second group, additive gradient echo, also known as adage, merge, MFFE, and venous bolt. Third group, steady state free precession, which is also called steady state free precession or fiesta. Any one of those will do, as long as we get good contrast between vessels, nerves, and CSF, and we have it. We've got an asymmetric loop contributing to the morphology at the base of the 7th and 8th nerve complex. Now, the 7th one is the first one you encounter. 7 up, coke down. The 7th nerve is in contact with this vessel. And this patient has ear pain. Now, the facial nerve is primarily a motor nerve, but it has a sensory component, and this is known as the nervus intermedius. And this patient has nervus intermedius syndrome. Now, even though the trigeminal nerve and the facial nerve contribute to the innervation of the tongue, as we'll see a little bit later on, if you've got fasciculations of the tongue, that usually drives you into another direction, like ALS. So fasciculations are not a component of either trigeminal neuralgia or facial neuralgia, hemifacial spasm, or nervus intermedius syndrome, an important clinical adjunct point. History is facial paralysis and dysphagia. There's left facial numbness. Patient has trouble swallowing and chewing food. Well, trouble swallowing is a rather amorphous diagnosis. The problem could exist in the swallowing mechanism, right, in the esophagus. It could exist in the cervical spine where there's dysphagia lusoria with spurs projecting against the esophagus. They could have reflux, they could have achalasia, but it's a neurocourse. So why are we going to focus on the esophagus? We're not. So let's move to something that's more relevant to the neural axis. And, you know, we have a group of nuclei that are responsible for taste. The nucleus ambiguous, the solitary nucleus, the nucleus solitarius. We've got the vagal nerve nucleus, and we've got the area of the brainstem that is responsible for swallowing. A more general macroscopic view of this clinical problem, and that is to help you out, the medulla. So let's focus on that. To take a page out of Michelle and Barack Obama, when they go high, we go, when they go low, we go high. We're going to reverse that. When they go high, we go low. So let's go low. High, low. So we're at the pons. We're at the middle cerebellar peduncles. We've got the brachium conjunctivum, the superior cerebellar peduncle. We've got the nodulus of the cerebellum. Looks like a little pseudotumor. And we've got the pyramid, the olive, and the inferior cerebellar peduncle, which has not gotten a lot of play so far, also known as the restiform body. At first glance on T2 imaging, which is allegedly sensitive, it looks fairly normal. Then when you blow it up and you spend a little more time looking at it and you decide that this is the area where the pathology could reside, making a clinical radiographic correlation because you're doctors, you studied your whole life, you're lifelong learners, you're brilliant, you're a member of the greatest club on the face of the galaxy. It's true. And there is some amorphous increased signal on the left. Is it real? Is it pulsation? I'm not sure. Let's go over to the flare on the left. The flare, allegedly, highly sensitive for assessing brain lesions, provided you have an abundance of white matter. That's also true for diffusion imaging. You need an abundance of white matter to improve the sensitivity of flare. So flare is less sensitive in the posterior fossa. It's even less sensitive in the spine. Do not use flare for MS plaques in the spine. And be aware of the delayed sensitivity and paucity of sensitivity for strokes and injuries in the posterior fossa for diffusion imaging. If you can't remember that, write it down. But there is an abnormality. Let's window it hard, right there. And it fits with the clinical perfectly. So what are we dealing with? This is a restiform body infarct. I can't tell you how many times I've seen giant restiform body infarcts that extend into the surrounding tissues, including involvement of the cerebellum, because it is a pica distribution, and these have been rendered tumors. I've even seen them biopsied. So involvement of the restiform body should always tip you off to the diagnosis of a pica infarct. So these occur along the superolateral medulla. They can arise from branches of the vertebral artery. The syndrome, you know from medical school, probably the syndrome you learned in neuroanatomy is Wallenberg syndrome. Maybe you learned about Weber syndrome also in the midbrain. and there are some other variations of that that we may cover this afternoon. These occur away, usually from the pyramidal decussation, and there are variants of this syndrome. One is called Opalowski syndrome, which is Wallenberg with ipsilateral hemiparesis, but without lower cranial nerve palsies. And here you do have pyramidal decussation involvement because the origin is from the vertebral artery rather than pica. So Wallenberg syndrome includes a myriad, because there's so many nuclei here, a myriad of symptoms, but the typical ones are dysmetria, where you have kind of trouble pointing, nystagmus, palatal weakness, hoarseness, dysphagia, this patient has it, Horner syndrome, ptosis, meiosis, anhidrosis, enophthalmos, facial thermoanalgesia. In other words, they don't have temperature sensation in the face, and contralateral body thermoanalgesia. This is also known as the lateral pontomedullary syndrome, and with that, we'll stop our discussion of Wallenberg's syndrome. Are there any other questions about it? Yes, the question is, there is nodular enhancement in the left restiform body. I should have brought it to your attention, I apologize. And it is nodular, which is a little bit scary. It drives home the point that some radiologists who are less experienced will look at a lesion like this and say that's a metastasis. And it will end up with something that is along the lines of the diagnosis of a metastasis, maybe a CT of the chest, abdomen, and pelvis, maybe a biopsy. Again, as mentioned, I have seen large lesions with this nodular mass-like enhancement in the acute and early subacute phase undergo biopsy. So your point is absolutely well taken, and in earnest, that is probably the clearest finding on the image. And I should have called it up. But it is still an infarction. And they often do appear tumefactive. Because remember, the posterior fossa is a very small space. So if you get a larger one, you're going to get a very puffy, mass-like appearance in the posterior fossa. Generalized epilepsy, intractable. Patient is 62 years of age. Now, why am I giving you so much extra time for something so obvious? Because I want you to be thinking about drainage, supply, eloquent brain. What areas are involved? Now let's discuss. You've already seen an arterial venous fistula, whose classic location is posterolateral, involving the lateral sinus, occasionally the cavernous sinus. Yes, there are other rarer locations. Now we're on to an AVM. Some of you are questioning in your mind, what is the morphologic difference between an AVM and an AVF? And that's where it's time to draw. So we have, well, let's use the appropriate color. We've got blue for veins, and we've got red for arteries, And they come together, and in a dural AVF, there is an end-to-end connection with nothing in between. In other words, a direct shunt. They touch end to end. What about an arterial venous malformation? It's called a malformation because the venous vessels and the arterial vessels come together, and then right in the middle are a rete of dysplastic vessels and capillaries that provide the interconnection for each. So morphologically, very different. Physiologically, though, they are both high-flow shunts. The classic cavernoma is a low-flow state malformation. The capillary telangiectasia is a low-flow state malformation. There is such a thing as a high-flow hemangioma, but it's uncommon. There are also giant dural sinus malformations that are high-flow. So let's move over to a discussion. The low AV shunting abnormalities are the simple hemangioma, proliferative angiopathy, and hemorrhagic angiopathy. There is no shunting in venous and cavernous malformations. Remember, a cavernous malformation is a malformation. A hemangioma is a neoplasm. There's also no shunting in the capillary telangiectasia and the thrombosed AVN. Venous shunting, pure venous shunting, is seen in sinus pericranii. AVMs, unlike cavernomas, which bleed at a rate of 0.2% per year or less, have a bleeding rate of 2.4% per year. And that is higher than aneurysms. They rupture 6.2% of the time, unruptured 2.4% in the first 5 years, and if they don't rupture initially, then their rupture rate starts to decrease. The increased risk of hemorrhagic rupture or hemorrhagic phenomenon includes deep venous drainage. Do we have it in our case? You have the case in front of you. Answer? Yes. It's draining around the brainstem, around the perimedullary and peripontine region. Is it periventricular or near or around or in the brainstem? Answer, yes, in our case. Does it have vertebro-basilar blood supply? Where do you think the blood supply is coming from? Probably the posterior cerebral artery circulation, don't you think? Are there intranidal aneurysms? Well, there are. There are too many large globular areas of flow void. I don't have the case up, but you can see them. Dark, round objects. But we can perform an MRI dynamically or non-dynamically to confirm. With each hemorrhage, the mortality rate is 10 to 15%. 25% will have a permanent, lasting neurologic deficit. You can characterize these by the Spetzler-Martin classification for AVM. First, size, less than 3, gets a score of 1. Medium size, 3 to 6 centimeters, score of 2. Large, greater than 6 centimeters, score of 3. Next category, location. Are they in an area of eloquent brain? If they're not, 0. If they involve eloquent brain that provides special, important, critical functions to the brain, they get a 1. Venous drainage. Does it go out? 0. Does it go deep? 1. So ours goes deep. How about our size? Our size is probably about 3 to 6, so that would get a score of 2. So now we've got 1 plus 2 equals 3. And finally, are they in an eloquent brain area? And the answer is yes. They're in the parahippocampal formation, even though they're in the non-dominant hemisphere. So that would get another score of 1. And so we have a Spetzler-Martin at least grade 4. So if possible, this will have to be dealt with. There are craniofacial metameric syndromes associated with AVMs in this entity known as CAMS. CAMS1 equals porencephalic metameric AVMs, in which there's brain dissolution or liquefaction. This is usually seen in the hypothalamus or the nasal region or the hypophysis. CAMS2, that produces a more lateral porencephaly in the occipital lobe, thalamus, and maxilla, so less midline. CAMS3 equals rhomencephalic involvement of the pons and includes the cerebellum, pons, and mandible. The only other comment I'll make is eloquent brain. Some of you may not know what eloquent brain refers to. It refers to areas that are sensory motor, visual, language, internal capsule, thalamus, hypothalamus, brainstem, cerebral peduncles, and deep nuclei. If we go back and scroll this one, while it strictly does not involve those structures, you can see a little bit of brainstem involvement, some subfrontal involvement, but it involves the entirety of the hippocampus and part of the parahippocampal formation. There is atrophy of the midbrain, so both primarily and more seriously secondarily, there's Wallerian degeneration of the right midbrain. So this is considered one that would involve the brainstem and involve eloquent brain. This is how you assess an AVM every single time. A 74-year-old man presents with memory loss and balance disturbance. I'm going to start taking a different tact. I'm going to try not to put up the key images so that you are forced to search on your own. We're getting more comfortable with each other. You've got an ADC map on the end. There is another ADC map, 5 from the end, just to save you some time. It's a big case. Right next to that, T2 Spadeco. Not overly impressive. Perhaps to get you a little more in the swing of things, I might ask you to look at the flare. The axial flare can be found on the 4th series in. So there are certainly some small vessel periventricular lesions. They are not at right angles. They seem rather polar in the front of the brain and in the back of the brain. That is not a typical distribution for multiple sclerosis. They are scattered. They do not have a temporal predilection. There are some abnormalities in the parieto-occipital distribution, but they are not periventricular. They're more peripheral. So if you're thinking about MS, perhaps not. We might describe these as small areas of punctate hyperintensity, which in a patient of this age, and I do not have her age, is it on the report? In a 74-year-old, most likely related to small vessel arteriopathy, venopathy, hypertension, or metabolic syndromes. You can put the metabolic syndromes in there, hypercholesterolemia, hypertriglyceridemia being the most common. End of parentheses, period. Other considerations include premature arteriosclerosis or vasculopathy from diabetes, and you could list a few others if you want. But that does not explain the major finding. Maybe it tips you off to a contributory finding, namely the small punctate lesions could be related or not, because everybody over age 70 in the United States has a few spots, about one per decade. In Japan and Okinawa, nobody has any spots. And that's why they live to 100, because they eat fish, green tea, and exercise a lot. And I will have my green tea here later today. So the finding is a pattern of patchy, but moderately symmetric parieto-occipital, cortical, and subcortical hyperintensity. So we have to come up with a differential diagnosis of disorders that preferentially involve the bioccipital region. Now, there are disorders that are thromboembolic that can involve the parieto-occipital region, like the artery of Percheron or the top of the basilar syndrome with the basilar aneurysm. But they stay closer to home, around the brainstem and the thalamus. Some of them will produce extension into the occipital region, like top of the basilar syndrome, with emboli extending posteriorly. So that would be a consideration had we had an aneurysm. Let's put up the T2. We don't. We don't have an aneurysm. That's a normal appearance of the basilar artery. What are some other bioccipital syndromes? Press, absolutely. Posterior reversible encephalopathy syndrome. So that's high on our differential diagnostic list. Just for giggles, another bioccipital syndrome is called Benson syndrome. The patient did have some cognitive deficit, and that is a preferential form of basically Alzheimer's. It's a tauopathy that involves the occipital area. So it's a variant of Alzheimer's. Let's talk a little bit about this entity. So let's switch over for a moment. And let me highlight the abnormalities for those of you that may not be familiar with this entity. And there is mostly cortical and peripheral involvement. Now, in my experience, there's one other very important entity to include here, and that is intracranial vasculitis or leukocytoclastic vasculitis. It is more often asymmetric, but can be symmetric. I am a little disturbed by this punctate lesion sitting at the pontothalamic junction. But I have seen, especially in young men and women, bilateral symmetric vasculocerebritis with this exact non-diffusion restricted cortical vasculo-inflammatory presentation. And for me, that is the major differential diagnosis. But if it's PRESS, I prefer to see no diffusion restriction, and I don't. In vasculitis, I also prefer to see no diffusion restriction, and I don't. But of the two, which one is more likely to have areas of diffusion restriction somewhere in the brain? Vasculitis. But PRESS can have it too. So headache would be a very important discriminator for PRESS and vasculitis, because all vasculitis patients have severe headache. PRESS patients have no headache or mild headache. Let's talk a little bit about PRESS. So PRESS, posterior reversible encephalopathy syndrome, another name given to it is acute hypertensive encephalopathy. It is reversible. Not always. We said there are some areas of diffusion restriction, but if you're taking an exam, it's reversible. And there are some exam takers in the room. Note, some PRESS, in my experience, 30%, so not inconsequential, are not posterior. And some are not reversible, 30% has been my experience as well. So the majority are reversible. It's a patchy, subcortical, PCA distribution abnormality. Why is it in the PCA distribution? Because the endothelial cells of the posterior circulation are smaller and therefore are more prone to damage from a hypertensive insult. So it's parieto-occipital. The diffusion tensor image is usually normal. The ADC map, which shows an increased value, is a manifestation of the hyperemic response that occurs to PRESS with swelling and edema. So as long as the cells have not been destroyed or killed, the ADC map values are high, the opposite of an infarction. This is very helpful. Sometimes it's confluent, but most of the time, in my experience, it is patchy. If the patient's blood pressure is normal, they're usually under age 20. The cause is severe hypertension. That's the unifying cause. It occurs postpartum, eclampsia, preeclampsia, acute glomerulonephritis, an often overlooked cause. So any patient with PRESS should have an immediate blood pressure check and a renal workup. Hemolytic uremic syndrome, HUS, thrombotic, thrombocytopenic purpura, TTP, and also, one that I haven't listed here, the HELP syndrome. Systemic lupus erythematosus is probably the primary differential diagnosis, followed by these two others. Drugs. This is a very important cause of PRESS. So after you have vetted hypertension, after you have vetted renal disease, the third thing you want to vet, because you're a consultant, you're on the phone, and you're saying, is this patient on cisplatin, interferon, erythropoietin, tacrolimus, cyclosporin, azathioprine, L-asparaginase. Those are the major drugs. So 3 areas to vet in suspected PRESS, and your clinician will love you. Amnesia, poor short-term memory. It's a quick one. I'm putting up the raw data of the MRA. Please observe that I much prefer the raw data of the MRA to the MIPT image. MIPT image is pretty, it's fast, but it's not nearly as accurate. And I'm going to stick with the T2 in the middle. Don't you think that's an odd takeoff for a posterior communicating artery? Should be taking off over here. Sometimes they'll have little infundibula at the base, about 2 millimeters in size, not to be confused with an aneurysm. Yes, there is a little bit of sinus disease for those of you that are a bit OCD. But all radiologists are a bit OCD, otherwise we wouldn't be radiologists. But it's not good to be an overcaller. You're better off being right smack in the middle or a slight undercaller. You miss a meniscus tear, you've done the patient a favor. It's true. Okay, so what are we going to call this? It is the most common, persistent, cortico-basilar anastomosis, which for the residents and trainees and fellows in the audience is what? Persistent trigeminal artery, right? And there are a whole host of them. Persistent otic artery, persistent hypoglossal artery. Let's talk about it. What are the implications of this condition? Well, the major implication is not confusing it with an aneurysm. Let's have a look. So here's a basic diagram. I don't have all of them on there. There's a persistent cervical artery, and if you are still here after lunch, you might or might see another persistent cortico-basilar anastomosis, just a tip. But the most common is the persistent trigeminal artery. I have a few others listed here: otic, hypoglossal, and the one at the bottom, a type 1, what's called a Pisa artery. We'll skip over that for right now. So as said, persistent trigeminal artery, PTA, is the most common of all. It may not be the most important. It often presents as the tau sign, which I'll show you a little bit later. Looks a little bit like a tau if you look at it axially on the raw data, which I had up on the far left. Go back and look at it. The persistent stapedial artery is rare. And it's an embryologic persistence that produces enlargement of the anterior tympanic area. Enlargement of the anterior tympanic segment of cranial nerve 7 and an absent foramen spinosum are tip-offs to the diagnosis of a persistent stapedial artery for the residents, the fellows, the trainees, and the test takers in the room. That's important. So if they show you a skull base with no foramen spinosum, that is your diagnosis. For now, I'm going to skip over the rest of my discussion of persistent stapedial artery, although it does present with pulsatile tinnitus and a red mass, and I have seen them stuck, punctured by a surgeon, at which point they call my brother-in-law, who's brilliant. He makes his own furniture, he makes his own wine, he can do anything. And when it hits the fan and people are bleeding to death, they call my brother-in-law Tom. So let's go to the persistent trigeminal artery. What's the most common cortico-basilar anastomosis? It's persistent trigeminal artery for trainees. If you're missing the foramen spinosum, then you should consider persistent stapedial artery. Its main clinical point is that it should not be confused with an aneurysm. A pituitary lesion. That's the history we're given. Okay, so while you're scrolling, some tip-offs to your approach for the Cella, which will be on MRI Online. Size. How big is it? But more importantly, is it coming from the Cella, or is it pressing the Cella down? What part of the Cella is it in? Is it in the pars distalis, the pars nervosa, or the pars intermedia? Is it symmetric? Can you see the pituitary tuft? What is the pituitary tuft, you might ask? Now, here's your Cella. And here is your pituitary stalk. May thicken up a little higher. And then you get inside the pituitary, and the portal plexus comes right down the middle. And it should not be displaced to either side. If it is, that is often a sign of an occult pituitary microadenoma. And many microadenomas are not visible. They are diagnosed by laboratory method, by seeing a prolactin level of somewhere around 50 to 100. 30 is about the cutoff. An elevated prolactin is not pathognomonic of a prolactinoma unless it is over 100, but it is relatively pathognomonic if it's over 50. 30 to 50 is kind of the gray zone. You can get prolactin elevations from stalk effect, compression against the pituitary or the pituitary stalk. If you have a lesion, is it invasive? What's the signal intensity? Does it have blood, fat, cholesterol, keratin, solid tissue, other? Has it invaded? Is it cavernous, precavernous, precellar, supracellar, retrocellar, infracellar? If it's gone far and away with necrosis and irregularity, it could be a pituitary carcinoma. If it has a blood fluid level in it or blood in it, the patient may be experiencing pituitary apoplexy. You've got to act. What are you going to do? You're going to call the clinician on the phone and say, draw a cortisol, draw a thyroid level, because those patients will quickly go into a coma. That's a critical diagnosis. Is there vascular encasement? Is there vascular occlusion? Has the patient previously been treated with bromocriptine or some parladil analog? Because that makes the lesion soft and gooey and difficult to remove. How does the lesion relate to the sphenoid sinus? Is there a sphenoid septum? Where is the relationship of the lesion to the sphenoid septum? Because if the lesion is on the right, let me draw it out for you. So let's say there was a pituitary adenoma right there. Well, let's put it over here. And there's a sphenoid septum. And they do a nasal splitting procedure, transsphenoidal hypophysectomy, and they go up and they get into this sinus. Oh, now they're in trouble. They're on the wrong side of the pituitary lesion. Now they either have to break through here or start over, which is a big problem. So do pay attention to the sphenoid position, its septum, relative to the position of the pituitary microadenoma. All right. So now let's talk about the case. It's a rather large lesion in the sagittal projection. It has intracellular involvement, but I didn't say pituitary involvement, I said intracellular. It has supracellular involvement. It's more or less intermediate, similar to the surrounding brain background. Let's go to the axial T2. It is bright, but they're not all bright. I'm not going to tell you what it is yet, but it is bright, suggesting that at the very least it has liquefied proteinaceous material. Could be water, unless you look at the T1. On the T1, can't be water, because it's not the same signal as CSF. So it has to be proteinaceous. So now we go to the coronal contrast-enhanced image. We have a sagittal contrast-enhanced image, and it is not enhancing. Now, macroadenomas enhance pretty uniformly. Microadenomas, they're cold initially, and they fill in at about 3 to 5 minutes, sometimes a little bit earlier. So you want to do your microadenomas dynamically, or you want to do what I do. Don't inject them. Don't bother. Don't waste $100. Don't give gadolinium to a 20-year-old woman who's thinking about getting pregnant. That's stupid. Because all you care about is a macroadenoma. A microadenoma is treated on the laboratory value. If they have a laboratory value of 50 and they can't get pregnant, you treat them with a Parladil analog, period, whether they have the microadenoma or not. The exception to that is microadenoma with growth hormone disturbance or some other unusual endocrine problem. But if it's simply galactorrhea, hyperprolactinemia, you should not, you will not, from here on out, consider giving gadolinium, and you will have to vigorously, rigorously educate your clinician. It's silly. But this is not a microadenoma. It's a non-enhancing mass, and it demonstrates what's known as the bear claw sign. We said we'd like to evaluate whether the lesion is arising from the sella or not. This one is arising from the sella. Is it from the anterior, pars distalis, pars intermedia, pars nervosa? This one's pretty big, so it's a little hard to tell. But clearly, it's not from the pars distalis, because the pars distalis is pushed forward. So what lesions, what primary lesions arise from the pars nervosa? Almost none. So you're only left with the pars intermedia. And since it's a little bit cystic, it's a proteinaceous cyst, it has a bear claw sign, it's a Rathke spout cyst, also known as a pars intermedia cyst, also known in some countries as a pituitary central cyst. These are often asymptomatic, but when they're big, they produce visual changes. And so they have to be sucked out from below. Let's see where our sphenoid sinus septum is. Hold on, let's go back for a minute. Our septum is over here. We have very easy access to our lesion from below, so we can suck it out of there. And again, when they're large, they have to be pulled out. When they're large, they can also produce diabetes insipidus and pituitary insufficiency. This is one demonstrated in a 15-year-old boy. And sometimes they will have a craniopharyngioma-like appearance. In other words, they will be brighter on the T1 weighted image, like this one, and bright on the T2 weighted image because of the high protein content. So what do? You might have to give a differential, but if it's calcified, it is never a Rathke cyst. Rathke cysts do not calcify. Craniopharyngiomas calcify. Here's what the Rathke cyst looks like. You can see it's not a pure cyst. It's kind of reddish. Sometimes they do have a little bit of blood inside them, along with extensive proteinaceous material and cholesterol. And on the T1 weighted image, it does demonstrate a slight blush of hyperintensity, the Rathke's pouch cyst. This is a 43-year-old female. So the patient had a pituitary microadenoma since age 19. She currently has an elevated prolactin. She's now 43 years of age. I have elected to put up the pre and the post T1 sagittal. Okay, I assume you've come to a decision. I'm just going to take a quick look at the axials myself. So we alluded to the fact that patients who have pituitary microadenomas don't need contrast. However, if their prolactin levels are rising, especially if they start to exceed 100 to 200, you have to be concerned about invasion of the cavernous sinus and growth of the lesion. If the prolactin levels are over 1,000, it's virtually pathognomonic of cavernous sinus invasion. If it's over 2,000, they have to have direct cavernous sinus invasion. Pituitary microadenomas rarely undergo transition to macroadenoma disease. In fact, more likely, the pituitary microadenoma gets treated and melts into a gooey material that may include some of the normal pituitary gland, and that is why clinicians hate to operate on individuals who have been treated with a Parladil analog. This case demonstrates a mass, some of which enhances and some of which does not. Some of the non-enhancing component may be related to areas of liquefaction or obstruction in the sphenoid sinus. The left sphenoid sinus and its septum are completely separate from the lesion. So if you get into the wrong side, you are in huge trouble. And when assessing a lesion like this, it is said that somewhere between 180 and more commonly 270 degrees of circumscription of the carotid artery is a sign of cavernous sinus invasion. Another sign, failure to identify any of the cavernous sinus nerves. We do identify several of them. It's probably the third nerve right there. There's another nerve, and here's another nerve on the contralateral side. So the jury may still be out on this one. Abutment, flush abutment, greater than 1.5 centimeters of the lateral dural sinus wall is said to be another sign of cavernous sinus invasion, and this exhibits that. And in my experience, the circumscription rule is less valuable than the abutment of the lateral cavernous sinus wall rule. Now, the lateral sinus cavernous rule is less specific. Sorry, it is more specific, but less sensitive. So if you have it, they definitely have cavernous sinus invasion. The pituitary gland has been resected. You can see it's kind of sucked down and over. Whether this originally was a pituitary microadenoma or not, I don't know, but I suspect it was. It's been over 23 years, and this is one that has undergone liquefaction. It's going to be virtually impossible to resect or remove. You might be able to debulk it, and as I said, rarely will they undergo macroadenoma degeneration. So this is a pituitary microadenoma gone awry with right-sided cavernous sinus invasion. As far as this low signal intensity area, The differential would include, and you'll have to put it in your differential, sphenoid sinus obstruction, tumor necrosis or tumor liquefaction, and that's pretty much it. Let's look in the axial projection. There is a fluid solid tissue level here, so that bespeaks of at least some element of sphenoid sinus retention cyst to account for the low attenuation area. There is the abutment of the lateral dural sinus wall. A fourth sign is bowing of the lateral dural venous sinus wall. We have it. We absolutely have it right here. Don't be distracted by this pachyonian granulation in the back. So I think that helps confirm the diagnosis of cavernous sinus invasion. While we're at it, if the cavernous sinus is invaded, we better check for Meckel's cave invasion. Let's do it. I'd like to see an axial T1 for that diagnosis. And I do not see Meckel's cave invasion. Here's Meckel's cave right here. And it still has a CSF-like signal. It is not involved. All right, let's talk a little bit about macro and micro adenomas. Switch over real briefly. So there is a Kadashev classification from 1989 of pituitary adenomas. The normal cella is about 12 millimeters. A small adenoma would be 16 to 25, and then you see the numbers: intermediate 26 to 35, large 36 to 59, and giant over 60 or 6 centimeters. They are also categorized according to direction of growth: infracellular, anticellular, retrocellular, lateral cellular, like this one, and supracellular. Cysts are found in 73% of prolactinomas, calcification in 80% histologically, but rarely found by MR. If you do very, very thin section CTs, you'll find calcification at a much higher frequency, but again, not with magnetic resonance imaging. We've talked at length about the criteria for cavernous sinus involvement. When you have larger pituitary lesions and they go up through the diaphragmacella will pinch them, just like this. It's called the figure of 8 or snowman phenomenon. When you have a firm, thick, hard lesion, like a meningioma, they will not get pinched. Meningiomas also have a more spreading type growth pattern. Here's an example of diaphragma notching. When you get really large macroadenomas, you have to be concerned about various forms of pituitary insufficiency, like this man who had lost sexual function. He was a hard-driving executive for a Fortune 10, $120 billion company who had sent him to a psychiatrist for a year because he wasn't as hard driving as he was before. His family doctor called me up and said, "Hey, I think this guy's got testosterone insufficiency. Could you do a pituitary scan?" Sure. Really smart family doctor. He comes in, his testosterone level was 0. So it isn't just prolactin we're worried about. We've got testosterone, we've got indirectly LH, FSH, we've got gonadotropes, we've got lactotropes. There are a lot of endocrine functions in this gland. There is exquisite demonstration of lateral cavernous sinus abutment with 360 degrees of encasement of the right carotid artery in a patient with a giant macroadenoma, demonstrating notching of the pituitary, creating the snowman effect. The snowman has a little head and a big body, cavernous sinus invasion, pituitary macroadenoma. History, occipital headaches. Patient age, "35. Simple case, important subject. There is a possibility for abuse of this diagnosis. It has been litigated in the United States in numerous large, respected institutions where patients who are young have undergone craniectomies, duroplasties, and procedures for this diagnosis unnecessarily. So you are the gatekeeper, and that's why your job is so important. If you're a really good radiologist, people will listen to you. If you're right 95% of the time, they listen to you. If you're wrong 95% of the time, they will never listen to you. You'll have a job or not. So let's go directly to the area of interest, the craniocervical junction. The findings are obvious. It's a Chiari malformation. What type of Chiari malformation? I don't need you to answer. I want you to decide internally on your own. And the answer is Chiari 1. Why is it a Chiari 1? Well, I did not give you a history of a myelomeningocele, which all Chiari 2s have. The patient has occipital headaches only. There is no cervical medullary kinking. There is no Z deformity of the craniocervical junction, something that might look like this. There is no dragging down of the medullary clava. The little bump that lives here is often pulled downwards. And so the diagnosis of Chiari malformation, in this case, can be made. Now, when couldn't it be made? The tonsils are low. They're not pointed or they're a little pointed. There is no syrinx. There are no bone anomalies. There are no bone anomalies. Therefore, you should make the diagnosis of tonsillar ectopia. So bone anomalies, syrinx, pointed tonsils, small occiput, crushed, squeezed, smallish looking from anterior to posterior cerebellum. That is when you should use the word Chiari 1 malformation, and only then. Otherwise, stay with tonsillar ectopia. The amount of tonsillar descent is far less relevant than you were initially led to believe in the beginning of neuro-MRI. And this approach has been gaining tremendous steam over the last decade. So we've got extensive tonsillar ectopia. If we draw a line from the tip of the basion to the tip of the opistheon, the cerebellar tonsils are 2.5 centimeters below that line. We said 20 years ago, 15 years ago, 12 years ago, that ectopia of 3 to 6 millimeters was diagnostic or pathognomonic of Chiari 1 malformation. That is untrue. We do have a syrinx. There it is, right on the bottom of the film edge. If you hit 0, well, actually it doesn't work. But if you look right underneath, if I could lift it up a little higher maybe, you can see that little slit-like syrinx being covered up by a few yellow lines. So the diagnosis of Chiari 1 malformation is made. Do we have platybasia? No. Do we have assimilation of C1 or C2? Sorry, of C1 to the occiput? No. Do we have C1, C2 fusion? No. Do we have clipophile abnormality? Hard to tell because we didn't scan down low enough. So fusion of cervical vertebral bodies, we do not have. Do we have a retroflex dens, which you've already seen? Answer, no. So we don't have the bony anomalies, but we do have the syrinx. We have pointed tonsils. We have a slightly smaller AP diameter of the cerebellum. The occiput is a little bit small developmentally, which is the cause of this abnormality. We have an ACM1. Let's talk about ACM1. In fact, let's talk about ACM. It's a mismatch between the posterior fossa and the cerebellum. We'll skip over the hydrodynamic theory or theories of Chiari malformation, but the syringohydromyelia is secondary. The presence of it is often an indication for surgery. It's one of the few solid indications for surgery where the patient improves. Most are sporadic, but when they are syndromic, they may have midline anomalies, craniosynostosis, and a mutation of the LHX4 gene on chromosome 1q25. You can also see posterior pituitary ectopia with Chiari-1 when it's syndromic, not isolated. It's also associated with macrocephalic syndromes, NF1, Soto syndrome, Proteus syndrome, and hemimegalencephaly. The overriding theme, the cause of Chiari-1 malformation, is underdevelopment of the occiput. We've talked about the craniocervical junction anomalies, and there are often accompanied arachnoid adhesions that have to be resected or lysed at the time of surgery. The tonsils are impacted or grooved against the opistheon, and the most common symptom is tussive headaches. 2 of my children have tonsillar ectopia without full-blown Chiari malformation. They get headaches and tussive headaches when they play sports in the heat. Okay, I'll live with that, as opposed to an operation. No, never an operation for a patient like that. The leptomeninges are thickened, and they too may have to be dealt with. Before you consider any operation for a Chiari malformation, you should search very, very hard for a syrinx. You should also make sure that you are not dealing with sagging tonsils from spontaneous intracranial hypotension or lumbar puncture in a woman who's had surgery with an epidural where they've torn the dura. Or you should make sure you have excluded a mass pushing the tonsils down or idiopathic intracranial hypertension, formerly known as pseudotumor cerebri. Chiari-2, easy diagnosis. Myelomeningocele at birth for you test takers. Hydrocephalus. It's almost always a lumbar myelomeningocele, and no, split cord syndrome or diastatomyelia is not associated with Chiari malformation. It can happen, but it's not common. This is a mesodermal dysplasia. Chiari-3 is an occipital encephalocele at birth, and often there's a mixture of Chiari-2 and Chiari-3. Chiari-4 is cerebellar hypoplasia with no displacement of brain through the foramen magnum. That is our discussion of Chiari-1 malformation. Shall we move on? Break time. Okay, let's take a fun break.